Hi everyone. I'm calling in from Ottawa, Canada, which is same sort of time zone as Montreal and Toronto for anyone who's familiar with Canada. And it's one of the, I guess it's the fourth or fifth largest city in Canada, and is the capital of Canada, but not the largest city by any means. I am the director here at the Ottawa Integrative Cancer Centre, and also for the Department of Research and Clinical Epidemiology at the Naturopathic College in Toronto. And I'm going to speak to you a little bit about the OICC, the Ottawa Integrative Cancer Centre, and its creation, and some of the research that we're doing and some of the patients that we're seeing, and hopefully stimulate some thought and discussion around that. So just as an outline, we'll be reviewing integrative oncology very briefly in the OICC, talking about the feasibility to implementation for the center here, including the model of care that we apply for our patients, a little bit of our patients, the kinds of people that we see, and the issues that they're dealing with. And then I'll talk about two of the major research studies that we have ongoing here. And then finally talk a little bit about some of the lessons that, that I've learned in the process of developing this center and reaching out and collaborating, if you will, with oncology colleagues at the hospital and in the community. So I think we all understand that cancer is has rapidly become one of the biggest killers in the world. Globally, in fact, is probably the biggest now. In Canada, it is the #1 disease responsible for mortality. And this is actually, these are the newer stats for 2017, which I haven't put in yet, actually show an increased level. More like 1 in 2 people will develop cancer in their lifetime. So it's a huge issue. And more than 1/4 of people will actually die from the disease. There's a lot of evidence to suggest from the WHO and from a lot of observational studies that cancer is a preventable disease. It's a chronic disease that doesn't have to be as prevalent as it is now. So I think there are great opportunities for changing the trajectory for this disease. Obviously, an aging population will see increasing rates of cancer as that develops. So just before I get into more of the presentation here, I'd like to define some terms. Complementary and alternative medicine, or CAM, as it's more commonly known, is an umbrella term that is used to define all of everything that is incorporated within complementary medicine. So that could be from prayer all the way to a very alternative, aggressive treatment that is using injectable therapies, but not done in the hospital. So it's a huge range of different therapies that are within the CAM umbrella. And I think really important to consider that when we're looking at different components, not to lump everything together, but to look at specific parts of complementary medicine to see what is useful and what may not be useful. And that's something that we're really engaged with. Alternative medicine is more in opposition to or instead of conventional medicine, whereas complementary is usually in addition to and alongside conventional medicine. And that's normally how people are using it, or as an alternative. And then there's integrative medicine, which is really where the therapy and the approach is done in collaboration with conventional medicine and not in opposition. But there's communication, there's dialogue, there is a working together, if you will, with the patient at the center to try to bring that care forward. So I think in terms of where we get our information on complementary and alternative medicine, it's important to think about this. Many times it's at health food stores. So a clerk at a health food store might make suggestions for therapies. There may be things in the internet that are very sensationalized about different complementary medicines to try to sell things, sell ideas or sell products. there's questionable there. We have certain shows. This one is from the States, the Dr. Oz show. Do you know, are you familiar with the Oz show? Anyways, this is one that's, you know, a lot of people get their information from on TV. And of course, there is internet searches as well. How much of this is good information? How much is misinformation? I think is a very important question, and one that our patients struggle with all the time. I think consequences of some of this misinformation is that patients may refuse what could be curative conventional treatment, like surgery for early stage disease, for example. They may have a belief that this is harmful, or that there are natural cures that are available, and therefore avoid conventional medicine. And so this is a problem of misinformation. They can incur costs associated with this, and they may take agents that may not safely interact with conventional treatments, and have their own side effects as well. There is the stress and the anxiety around having too much information that is not good, and conflicting information. We deal with this all the time in integrative oncology. And then when the communication around this kind of care is not good with the physicians at the hospital, it can create a dysfunction in that therapeutic relationship. And then you get patients that are doing things on their own without any communication. So really drives the idea that an integrative approach is very supportive for the patients as much as possible. And this is the inclusion of evidence-informed, not absolutely strictly based, but informed by the evidence for complementary medicine alongside and ideally integrated with conventional care. And there's an emphasis on a whole person approach, where the pathophysiology of the disease is important, but it's one component. So we look also at the mental emotional health of the person, where their spirit is, and how they are coping with the disease, and how they're all the different side effects that they may be dealing with. So really trying to provide patient-centered care that is individualized to their needs, and that incorporates a more of a holistic approach to care. These are some just logos for different interesting and important, I would say, groups that are working on integrative oncology. There's the Society for Integrative Oncology. They have a conference that's going to be happening, their 14th conference this November in Chicago. And that is a very multidisciplinary collaborative group that has oncologists, nurses, naturopathic doctors, patient advocates that go there, and really they're developing the evidence around this. So if you're interested in this area, I would highly recommend the SIO. The Oncology Association of Naturopathic Physicians is a group dedicated to naturopathic oncology. And then there's the OICC, which I've slipped in there. And then we have the Knowledge in Naturopathic Oncology website, which is trying to help develop some of the evidence around that as well. So I think the need for this is really driven by patients. They want to see this kind of care. And there is a huge, there is a majority of patients that are using complementary medicine, and they want to do so in a way that's safe and informed and collaborative as well. And really there's a lot of research needs that we need to build on for integrative oncology, that looks at the impact of care, its efficacy, its safety, and also at the cost effectiveness of this application. There are lots of opportunities, I would say, both from the research and from being a clinician to support patients. There's no question that this kind of care has an impact on quality of life. We see it every day. And managing symptoms, and a lot of it's about empowerment for the patient, but giving them tools for themselves. There's some potential for extension of life that has been shown with certain therapies that we need to build on the evidence around that, but there is some compelling early data that yes, indeed, integrative care can help prolong life. Really assisting in their decision-making process is essential, and helping them to navigate between good information, bad information, and what they can be incorporating safely. and then also to help them to tolerate and to go through conventional care more effectively is one of the benefits as well. We look at supporting and strengthening the body's internal defenses, and as mentioned before, educating and empowering patients. So the vision for the OICC was really to create a sustainable center dedicated to providing and researching integrative and preventative cancer care that would lead to the creation of other similar centers as well. And our measures of success is really to see from the patients how well that's happening and to conduct the research that's necessary to document that. I won't go through this whole slide. You can find it on the website if you'd like, but really it's about a whole person care, our ends to bridge between complementary and conventional medicine, to provide evidence-informed resources, to do research, to address some of the environmental contributors to cancer, and to be a resource for training and education in integrative oncology. So this is one of the reasons I am so delighted to speak to folks in Brazil. It's wonderful. Thank you for inviting me. So yeah, we've been there. I'm going backwards here. The pillars of care for the OICC is really, we want to focus on healthy nutrition, healthy movement, exercise, and fitness, which is a extremely evidence-based approach to cancer care and prevention. So we help to coach people to become more fit, to adopt this exercise into their life, and that's a very important. We look at helping their mind, body, and spirit, the whole package. We look at maybe shifting the environment that they live in, whether it's social environment that creates stress, or it's you know, too much consumption of plastic in the microwaves and things that may be contributing from an environmental standpoint to progression as well, although we have limited information on that. And then healthy physiology. How do we help support the immune system to be active against the cancer? How do we help to reduce inflammation in the body? How do we help to change metabolism, perhaps, so that the cancer is less able to grow in an organism? Very quickly, in terms of funding, people are often wondering how we are supporting ourselves. We have had seed and operational support. We are covered by fee-for-services, both through government-covered services through the medical doctors that work here, and then also for fee-for-service by the patients, and then also from some of the programming that we have. We have research support that helps that staff and infrastructure. And then we have developed a foundation for philanthropic support to expand on our care to people who can't afford this, and to expand on the research in the program. So I won't spend very much time on the feasibility study, but just to say that 6 years ago, or actually I guess 8 years ago now, we started a feasibility study to look at how could we create this. And the components of the feasibility study were to, one, do a systematic review of the literature to look at what has been accomplished in other countries in terms of integrative oncology and centers for integrative medicine in cancer care. And so we did that. We then also did a qualitative analysis and study with patients locally and with physicians in the hospital, oncologists and surgeons, and then we spoke to complementary and alternative medicine practitioners as well to try to get a sense of what could we achieve here and how well could we do that. And then we went to visit some of the different centers across North America to understand better what they do. So the first, we've published on these findings as well, and those are available, I think mostly in Current Oncology is the journal that we've published in. This is part of the systematic review. We did a standard process for extraction and screening of a number of articles, and then we looked at a number of data points for what were important to help us guide us in terms of that. So it was like, you know, the article, the clinic, the components of care, the organizational structure, and how the patient interacted with the clinic, and were there any measurable outcomes followed. So we did find many examples of centers, over 20, most of which were in the States and in Europe and in the UK, in fact, with only 2 examples in Canada. And I don't think we found one at the time in Brazil that reported. That doesn't mean there isn't any that exist there, but there was no reporting on that in the literature, at least in terms of our inclusion criteria. So it was interesting, lots of variation, but it certainly helped us. So that is, as mentioned, published in Current Oncology in 2012, which is an open access journal if anyone's interested in that. The next part was a qualitative study, so we assessed the needs and perspectives of cancer patients, their caregivers, and the healthcare providers. We looked at potential models for collaboration and how would patients flow through the center, and then some of the outcomes that we could look at to evaluate. And then we looked at what were some of the perceived barriers or facilitators to trying to create this kind of a model in Ottawa. So we did reviews with interviews for about an hour, roughly, with these different practitioners and family members and patients. You can see the breakdown as far as the types of participants. We had 39 that were interviewed. And this was done by a qualitative researcher to code the information in a way that had some rigor according to qualitative research methodology. So the 5 major categories that we came up with as sort of thematic groupings were related to the model of care, the physical setup, the values inherent to a center like this, how to evaluate the impact of the care in the space, and then what were the facilitators and barriers as well. So I think it's interesting to hear from the patients, well, to hear from the people that we questioned. So, and this is just a little tiny snapshot, but the cancer patients, the question need to be asked the patient right at the start, as opposed to advice being given. They want to get the input essentially from the patients in the whole process. This was an important thing for them. And from the oncologist, it was important. One of the themes was research and evaluation, and how important that would be. And then another theme was just relating to how people would be paid, in fact, and compensated in a model like this to help support an integrative approach. So moving to implementation. We looked at creating what we considered to be a good healing environment that is warm but still professional and clinical, but and is welcoming, not hospital related. One of the things that the patients especially were saying was they did not want to see this integrative center in a hospital setting or in the cancer ward, because they had some associations with that that didn't feel good. So having this in the community made sense. Being multidisciplinary was important, and having credentialed practitioners that have experience in cancer care was important, with clearly defined roles and scopes of practice. Also, a component of this was that it's to be non-hierarchical, so there wasn't such a structure around how you know, the physician is the top and everything else responds and to that, but that is more of a collaborative effort around patient-centered care, that the patient is truly a focus, and that there's communication between the practitioners, so that there is either open access for patient files and shared electronic records, and we've adopted that process, and it's worked quite well. Other things were that this was to be individualized care, obviously to the person, not a cookie cutter approach. That, you know, standardization is good, but we want to focus on that person, and that there should be some free care as well, and for those that could not afford it. And so we've adopted a subsidized care model where people can apply for that and receive a proportion of their costs are covered, and the foundation is driving that more now. The goal for integration with local hospitals was really important, both to give educational opportunities for the hospitals and also to have access to the electronic health records. And it wasn't the case initially, but I think 3 years into running the center, we were able to get access to the hospital records. So When I'm seeing a patient, I can look on their records and I see the most recent lab results, their imaging results, so I can know where they are in terms of their progression through the disease and how they're responding. And that's very, very helpful. And we have a communication process back through consults to the patient's physicians as well. One other part was that we were to identify and have a care coordinator, a central point of contact for the patient that could be responsible, that would be responsible for managing their care to some degree. And we've done that, and then also to have an active and collaborative research program. So this is just a little schematic to show how patients come to the center. Typically they're referred, well, not referred, they don't require referral, but they can come, they hear about this from the website or from family members or from another practitioner at the community or at the hospital. They book in, they see a care coordinator. If they're eligible for research, they'll be given consent for some of the research studies that we have ongoing. And then they'll be referred typically and triaged to different types of care, whether it's individual therapies or it's a program of care. And often they're using multiple services in that way. So we do have a number of different individual consultative type services. We have 3 naturopathic doctors. We have 1 medical doctor, actually, yeah, and it's 2 medical doctors and 3 nurses currently. We've got an acupuncturist and an assistant, and we have massage therapy, physiotherapy, reflexology, and then we have what we consider mind-body medicine, incorporating hypnotherapy, something called conscious living coaching and yoga therapy. And then we have a psychiatrist, a psychotherapist, and a cognitive behavioral therapist as well. So it's sort of a variety of different types of therapies, all sort of geared at addressing the needs of different patients based on how they present. We have programs that are focused, in one case, our Head Start programs focused on women who are newly diagnosed with breast cancer. We've done an anti-cancer lifestyle program. Actually, we've stopped running this one, but we found that a bit long, in fact, and hard for the patients to adhere to. And then we've got weekly workshops that we provide for our patients as well to help support them in making some of the changes, especially in nutrition or in activity and fitness. So our patients, the time when people come to see us, often, very infrequently, do they see us before they get the diagnosis. People are not really motivated until they have a diagnosis of cancer. I think it's no surprise. We would like to see more primary prevention, but it's a small proportion of our patients. We're seeing more and more come to us right at diagnosis now. They have some understanding of what we are doing, and they want to incorporate an integrative approach right at the beginning, and so we have that and growing. Then there's those that are in conventional therapy, usually with chemotherapy or radiation or soon after surgery. We see a lot of these patients. And then we see another large group right after they've been sort of discharged, if you will, from the hospital, and they are without the same kind of follow-up that they would normally have. So they are motivated at this point to do what they can. And then we see about 20% that are really seeing us as a last resort. And they have no other options. They want to do anything possible. And those are difficult cases, as you can imagine. We see about 10% of our cases, less actually, that are truly seeking an alternative to care. And in those cases, we really try to help to give them good information, but and we support them as best we can. So people come to us for support and management of their symptoms, to slow their disease progression, to prevent recurrence, to cure their cancer and sometimes a last resort, and as mentioned, as a complete alternative in cases. We do put ourselves very much as an integrative center. We won't turn people away, but if they have early stage disease and they have a surgery that could cure them, we don't offer them certain therapies that they might see as viable alternatives. So we really try to help give them the right information so they can adopt an approach that's going to be the most supportive for them. And some people come to see us because their wife or their father or whoever else or told them to come. um, we see patients at different stages. First stage, immediately following diagnosis, during second stage, during conventional treatment, and third is sort of after they've been discharged, as mentioned before. But I've gone into that, and they each have their attendant issues that they present with, obviously. So I'm just going to give you a small subsection, a cross-section analysis of 1,200 unique patients that we saw in a 20-month period to give you a better flavor for the kind of types of patients that we have in the States. So a variety of, majority are female, and the majority come to us between really 40 years and 70 years of age. We see a few pediatric cases, but infrequently. The diagnoses are very broad. We see a lot. The majority are, well, the third is breast cancer. And then you can see all the way down the line. There are the different types, so it's quite a variety. Following, in most cases, sort of the trend of common cancers. And then, interestingly, here in terms of stage, we've got you know, stage 3 and 4 are actually the most common cases that we're seeing. So where it's more of a serious situation. The individual services that are seen, people of the 1,200 or almost 1,200, I should say, all of them saw one type of service or another. 1,000 of which used naturopathic medicine. 270 saw the acupuncturist. Only 84, in fact, availed themselves of mental health services. 174 for the mind-body therapies like yoga therapy, hypnotherapy, that kind of thing. 273 went to see one of the massage therapies or physiotherapy, so the physical therapies. And then we had 340 that saw one of the medical doctors. And then only 84 actually had an offering of intravenous therapy, which is what we offer to in certain cases. And then you can see the frequency of the visits. So the average visit number per patient was 3 for the naturopathic doctors, whereas it was 13.7 for the acupuncturist. So you can see the variation in the frequency of visits based on that. 12.1 visits for mental health, which is interesting, quite a high proportion. Not such a high number of patients, but those that are using it intensively. And you can see the difference. IV therapy, the highest frequency, they come for quite an intensive period if they're using that. So that just gives a sense of some of the patients that we see and the scope of practice that they're receiving. So our research program really consists of 3 parts. We look at synthesis research, which is exploring research that's already been published and trying to bring that information together in a way that is digestible and readable by our patients, and also is well cited and a reference for physicians that want to look at the evidence more closely. And we've done quite a few of those. We're expanding on that. The observational research I'll talk briefly about, which is just looking at what people are receiving in the community. And then we have a few clinical trials that we have ongoing, one of which I'll speak to a little bit more. So this is just a poster on some of the knowledge synthesis that we do, and we generate patient and professional monographs. Those are all available at our website, and there's a lot more work to do on that, but it's important. The Cusio study, which is the observational study that I'll describe, is it's a study that's in collaboration with Bastyr University in the United States, and we are looking at essentially following and measuring survival for advanced stage breast cancer, colorectal, ovarian, pancreatic cancer patients who receive advanced integrative oncology treatments. And these are treatments that are recommended by naturopathic oncologists in the community in these different clinics for these patients. And we're also doing a sub-study related to their quality of life. And we've added another sub-study related to cost impact of the care. Now, there's lots of issues, of course, related to biases being an observational study. But what we want to do is to document the types of interventions that are being recommended to these patients, publish that information, and then look at what is the trajectory for survival for this group, and then compare that to registry-based data and other clinical trial data. So these are the different clinics that are enrolling patients across both Canada and the States. Our enrollment, this is a little bit dated. I need to bring it up to speed, but we're roughly here. Yeah, this is an old slide, but we're on track to be a little bit behind, if that makes sense. So we're looking for a goal of 400 patients across for the full enrollment. Preliminary findings, a lot in Canada. We've got majority of our patients from British Columbia, and then some in Ontario, and then the cancer types that we're looking at are actually pretty close to what we predicted. Breast, pancreatic, colorectal being the most, and then ovarian and pancreatic following. But we'll look forward to publishing that information down the road. The next study, which is the Thoracic Poise trial, is a pragmatic clinical randomized controlled trial. It's work that I'm doing with, well, there's a whole group of us, obviously, but my brother's a thoracic physician, surgeon and physician at the Ottawa Hospital, and a researcher as well. And so we were doing this together. It's really a truly integrated approach, I would say. We've got people in the group that are involving oncology, pharmacy, surgery, naturopathic medicine, and dietitians as well. So it's an extremely collaborative process to develop this trial. The goal of the study is really to look at what does integrative care, what can it achieve for patients who have thoracic cancers, either lung, gastric, or esophageal cancer, that are eligible for surgery and would be receiving integrative care for a month prior to surgery at least, and then for a year after that. And so we've got a number of stages that we're looking at. The first stage is a feasibility study to see how this rolls out well. And then the second stage, second and third, are expanding it into a larger scale randomized controlled trial. So we've just completed ethics. It's taken a year and a half to develop the intervention and to get it through ethics. It's actually probably longer than that now. And it's a 12-year study, so no results for a long time. But it's a pragmatic RCT, as mentioned. Our hypotheses are that the integrative care will improve health-related quality of life, reduce adverse events associated with surgery, improve certain biological surrogates related to immune function and inflammation, and overall improve survival, looking at a 5-year time frame. And as mentioned, the patient population are those who are eligible for surgery with thoracic cancer. The whole intervention development process was really a very, like as mentioned, collaborative process and an intensive process that we looked at the evidence for these different therapies. We looked at the safety of the different therapies to make sure that these would be okay within the context of the trial. How feasible are they? Was there what cost was associated? How invasive were they? And could patients comply with these therapies? It was to be consensus-based. So we actually surveyed the naturopathic group, focus on naturopathic oncology, about therapies that they would use for this group. And we had 44 respondents out of a group of 600 or so. And so we take that information and then we evolved it and discussed it with the group and the team to have a consensus-based approach. And that this also had to be holistic across a number of different goals. So yeah, there's a practice review, an evidence review, there was expert opinion. We looked at the interventions. We had a meeting with the entire team, and then we excluded interventions with a low ranking according to those different principles. Then we subjected the ones that we had for a full safety review, and reviewed that with dietitians and pharmacists as well in terms of the interactions potential. And then we looked at some of the side effects and contraindications to manage and monitor this as well. And then out of that, we came with a core palette of therapies and then an optional palette. And so that that actually is going to be published hopefully soon. But really the domains of care, we're looking at providing care through specific natural health products, things that are there to boost the immune system, to reduce inflammation, to help with surgical adverse events. And then we have sort of mind-body medicine therapies. We have nutritional approach, and we have physical fitness. So it's quite a large group of therapies that are going to be given to this group. But we're standardizing it so that everyone is going to be receiving the same thing, and we won't know what is contributing what effect. But really, it's proof of principle to see if we can have an effect on long-term outcomes for these patients through this integrative approach. Yeah, and there may be more questions on that. Happy to take those. Lessons learned, I guess, just in terms of this, there's been challenges with integration both internally in the clinic and externally, and trying to implement a model of care that everyone actually can buy into and supports ongoing. There's the usual physical software infrastructure needs. Funding this has been a challenge in many ways, but I think we're at a place now that we are secure, and getting the right team in place is essential for a multidisciplinary team. We've had lots of resources, not least of which are the patients and their families, foundational funding, practitioners, the research, and aligned organizations, and also community leaders that have really taken this initiative to task and have really contributed. The importance of collaboration and integration has been essential, both internally amongst the practitioners. Everyone needs to be on the same page. We want to have consistency. We want to make sure that we're meeting patient needs, that there is effective follow-up for the patients, which is a challenge. And that same thing from a research standpoint that I was there. And then collaboration externally with the hospital and the physicians and other practitioners has been important to get access to hospital files. And we've been helping through that with the consultation notes, and referrals have supported that. And really a lot of outreach and education has been essential as well. Barriers that I would say internally to this whole process would be people who have a certain high ego needs, and so trying to find people that can work together in a team is really important. Solo practitioners that are used to doing things their way doesn't usually fit. Putting the patient first, and having, if there is a sense of hierarchy, that's a barrier. So we can always elevate the patient to be the top of the heap, if you will, and that everyone can usually get behind pretty well. The communication and cooperation is essential, and resistance to change as well, because we have gone through lots of evolution in this whole process. And there's a lot of time needed to collaborate and to communicate and to share what we're trying to do. Facilitators, a care coordinator has been a facilitator. Shared patient files has been helpful. And interprofessional communications has been very helpful in terms of, and just having informal meetings, lots of time for discussion has been essential. External barriers, resistance to change, typically, certain biases that exist within the conventional system, physicians that are trained not without any exposure to complementary medicine, or perhaps with a few thought leaders that are very resistant and believe that anything alternative is quackery. We still encounter that, unfortunately, but it's diminishing. Patients' lack of self-perception of power is one of the things that is a barrier, that just want to be told what to do. So we're trying to empower patients. I think helps them, but not everyone is actually open to that in a way. There is still, we need more evidence. So having more evidence allows more ease of adoption. And the cost of care is certainly a barrier. And the fact that it's not covered by the government services here is a limitation. Some of the facilitators externally in the community have been champions in the hospital. We've had some oncologists that are very supportive of this, and leaders in the community as well that have helped, in the media. Education and outreach, mentioned, can't do enough of that. Having one-on-one communication with different clinicians has been really, really helpful. Once they understand that what we're trying to achieve, we're not trying to get in the way of their care, we're trying to support their patients as well, then that it invariably leads to much greater openness. Partnerships, we have a not-for-profit status, which helps a lot. The research that we're doing and also patients are essential. So I think I won't belabor this, but lessons learned, relationships are great. Ability to evolve and adapt have been important. Supporting others, being open and transparent, being proud and strong in what integrative medicine can achieve, and not apologizing for it. Having a persistent positive outlook, and research has been fantastic in this whole process. Finding our local champions and communication and collaboration. So with that, I think that brings me to the end. Here's a loon from Canada. And thank you. I don't know if there's any questions or comments.
Dugald?
Yes?
Can you hear me now?
I can, yes.
Oh, that's good. So my name is Sam. I'm from Santa Casa de Passos, okay? It's from Brazil. We have a question. We'd like to know about what you think about the resistance of the conventional doctors to change to naturopathy. Can you see this resistance?
Yes.
And how can you manage that?
Yes, there is resistance. I would say that it really depends on which physician that we're dealing with. Some of the oncologists and the physicians are quite open and supportive of their patients adopting an approach that we provide, as long as they're well informed. I think that so yes, there's a group that's quite supportive. There are some that I would say are on the fence, and that aren't supportive, but they don't dismiss it either, and they just sort of don't have anything to say about it usually. And then there's a group that are sort of actively pushing their patients to not do anything considered alternative or complementary in the community. So we always recommend that patients are fully disclose their care that they're receiving, and we try to, if there is resistance, we try to engage with the oncologist as much as we can to give them some evidence for what it is that we're doing and why, and open that discussion. And that's helped in many cases. Everyone's busy, so it's a challenge to find that time to be able to do so, but that's there. I think, the challenge is that in complementary, like, this is the whole thing of seeing this umbrella of CAM as this big broad thing, because there's stuff that happens in the community that I feel very bad about. Like, I wouldn't want my patients to do. They come to me with certain ideas and I'm like, no, that's crazy, I won't say it like that, but so I consider myself quite a skeptic. And so, I think if we can inform the patient or have them be good consumers of information so that they can evaluate what are the costs, what's the reason for doing this therapy, what are the possible side effects, is there any interactions with their chemotherapy or radiation? So they have to be able to ask good questions and not just accept everything blindly. And so, you know, there is resistance, and I think in some cases it's rightly applied. I think for naturopathic medicine in Canada, in the States at least, there are good regulations around naturopathic medicine. The education is quite rigorous. It's a 4-year full-time postgraduate program. There's accreditation, you know, so that doesn't mean you're gonna get always good care, but you at least have certain way of knowing that. But then there's other people that don't have any credentials and are practicing alternative medicine, and that can be problematic. So it's I don't know if that really answers your question, but it's a process. Okay.
Okay. So once again, I'd like to thank you very much for your speech. Okay. Thank you.
Thank you. Okay.
Bye-bye.
Bye, everyone.